I think it's nice to be back in a way. Really, really nice to be back in Marginal Way. So I actually have to do this to basically focus a lot on some of the outpatient infections that we see a lot. So basically some respiratory tract infections. That's what Andrea wanted me to talk about. So I am going to talk mostly about that, but I'm going to throw in a couple other things along the way. So, yes, it is. Okay. So first of all, what we're going to talk about is just antibiotic prescribing concerns. We'll talk a little bit about respiratory tract infections, new FDA alerts that came out on some of the antibiotics chip, and then my specific pet peeves, and then some new antibiotics that I'm hoping that you guys don't see. So unfortunately, I think this is very true. There's an awful lot of antibiotics that are out there, and we're going to talk specifically about that. It's actually, some of the data is really pretty scary. So 10% of all ambulatory visits actually get patients will get prescribed antibiotics, and 61% of them are actually broad-spectrum antibiotics, which includes fluoroquinolones and macrobid. And for the most part, those are used for or seen in patients who have respiratory complaints. They go to the ER, or if they're over 60, where you normally will see it. I'm actually a little bit surprised by some of these numbers, that only 9% of those antibiotics are actually prescribed for UTIs, but clearly the vast majority of them are the ones for respiratory conditions, most, by the way, which are viruses. So we'll talk about that. This is the scary part, right? So 842 prescriptions per 1,000 people in the U.S., but that includes kids. So it's 789 for every 1,000 adults. That's a lot of drugs that we're pouring out there, a lot. So this great article that came out that basically said this is an urgent public health threat. We got to get this under control. And clearly there's a lot of other issues, right, with people, with antibiotics in animals and antibiotics that are used indiscriminately, both in the inpatient as well as the outpatient setting. We're really causing problems down the road with all these antibiotic resistances. And it caused lots of deaths. We've had a couple carbapenem-resistant enterobacteriaceae infections at Maine Med. And let me tell you, we struggle with what we're going to use to treat these infections with. They can be very bad. We have to use combinations of antibiotics, some of which are pretty toxic and make me very nervous. We have deaths, but they clearly have been in other places. And it's just a matter of time before they come to Maine. You know, they're down in the bigger cities, but it's coming. If you thought this, I mean, we could actually fund the wall. If we just stopped with all these antibiotics, Trump would be happy. Anyways, the other thing about all these adverse drug events is that 20% of all of the ER visits of patients that go in with adverse drug events are because of antibiotics. So it's a problem, right? Some people can go in because adverse drug effect is nausea and vomiting, which I personally don't say that, which is a big deal. But it cannot go all the way up to Stevens-Johnson, right? So you have the full gamut on some of these things that people will show up to the ER for. Actually, up to a quarter of people will have some sort of an adverse event. That's a lot. And here's the real problem. 50% of the time, they're either unnecessary or inappropriate. Inappropriate means gross, wrong drug, wrong length of time. So there's a lot that's put into that. We have seen that there has been almost a 20% decrease in prescriptions over the past decade. However, quinolones and macrolides have skyrocketed. So that's, you know, we started to back off on some of the drugs that we've used in the past, but unfortunately the broad spectrum ones have really taken off. So the one that is the most common for macrolides is the azithromycin. because it's very easy to use. We all know that, right? You give a Z-Pak, it's either 3 or 5 days. Thank you very much, you're done. It stays in them for 10 days. We'll talk more about that in a second. Depending on how old you are is going to depend on what your frequency is of getting prescriptions. It's a big difference, right? It's almost double if you're in your 20s and 30s compared to when you're over 65. So a lot of drugs we're putting out there. And this is, I to see that we beat them by 100%, right? Diminishing, yes. We'll let that go. So this is kind of interesting stuff. So who gives the most antibiotics, right? So family practice is the highest users of antibiotics. And if you think about it, they're crossing the spectrum, right, with all the babies and stuff. Pediatrics, very high. We come in number 3 at 383 antibiotic courses. And I was shocked about the dentist. I was shocked. So on Monday, I called my dentist. And I said, what the heck? What are you guys doing? I told him it was 10 o'clock in the morning. And he said, well, Patty, I've already done it 3 times this morning. I was like, 3 this morning? What are you seeing? It was like, well, for gingivitis and for this and for that. Unfortunately, dentists are the ones that shown are the least likely to follow guidelines and the most likely to use them inappropriately. Now, I did not get into that on Monday morning because I have an upcoming dentist appointment, so I was a little nervous about that. Dermatologists actually are the highest number of scripts per provider. And think about why that was like, and it was like that. And in fact, mostly is because of, think of acne and rosacea and stuff like that. But interestingly, there's been a huge decrease. I think from 2006 to 2016, there's been a 37% decrease in the extended courses of antibiotics. But short term, there's a huge increase. And those are patients who have had skin surgery, might have post-op infection or something. They're very aggressive with some of those antibiotics. So that surprised me too. I did not see that coming. I have not talked with them about that, but it would be kind of interesting. And it's really, whether or not you're going to get antibiotics depends on where you live. So if you really want them, you should head down to Kentucky because they give out a lot. But look at this, Alaska. Probably aren't that many physicians that are there. You have to travel really far. Really, not that many get given out. They're given out in the South. 60% are given for viruses. Again, out west, they do best. If you have access to health care, if you're obese, if you're female, if you have low income, that puts you at a higher risk for having more antibiotic prescriptions written for you. Whoops.
Does that include urgent care?
Yes. It includes everything. So here's the number of scripts. Now, this looks a little bit confusing. So this is basically going to be amoxicillin and ampicillin, and down here is going to be more like dicloxacillin, ones that have a broader range of activity. Macrolides are number 2, barely, and then they're pretty much going to be oral cephalosporins, and you can see tetracyclines and Bactrim are down pretty low. But when you split it up, azithromycin is the number 1 drug that is prescribed. And just that if you look at the treatment guidelines for any respiratory tract infection, the drug that is suggested is actually a beta-lactam, not a macrolide. Unfortunately, that apparently has not made it through to mainstream medicine, I guess. So this is from the CDC, 2016, and you can see they were talking about 270 million antibiotic prescriptions, and that's equivalent to 836 antibiotic prescriptions per 1,000 people. So the South, where it's not so good for us to, well, depending on your point of view, not good for as far as antibiotic resistance. Here we are. So we're in the 687 to 744. Not as good as out here, but that part is, kind of creeping up on us. Vermont ended up doing that. I don't know. I think, maybe it's just fewer people, but that's where we stood in 2015. We had 132 outpatient prescriptions per 1,000 people. So we're actually better than a lot, but we have definitely room to move. Talk about a few of these. I'm not going to talk about pharyngitis. I'm not going to talk about the common cold, except I have a cool CT to show. Doing medicine, obviously people come in a lot with upper respiratory tract infections and complaining of this, and it's 1 in 7 adults in the previous 12 months will have had sinusitis. So it's very common. So in women, the question is why is it more so in women? Is it because our nasal passages are smaller, we have more congestion, leads to more of these complaints? I'm not entirely sure. And normally people get several episodes per year. And really, despite the fact that there's a lot of drugs that are used for this, at most 2% of the rhinosinusitis have a bacterial origin. So 7 of the time is when you should be using antibiotics.
The young women tend to have child care, teaching.
Right. That's very, but that's probably going to be all that viral stuff. And that comes into play with what drug I would suggest too. I was recently at a friend's house for dinner, and she is a physician that hasn't worked for a while. And oh my God, they started calling me like a week before, complaining of her. Actually, not a week, 3 days before, complaining about how miserable she was, and her doctor her in-med doctor would not give her antibiotics for her infection. And her husband's a physician. He called me and tried to, get me to do it. And I was like, go intramed, man. This is really great. She was still warm when I got there, and she ended up getting it, so I was very proud. So these things need to be up like in the patient exam rooms for them to see this. So really look at this. You can feel pretty miserable and have this viral cause that can last. It can go, more than 2 weeks. You can really still have some symptoms. The aerobes, the gram-negatives, that's in the strep pneumo, that's when we start getting into trouble. But that, again, is out several weeks before you start having problems. This is when you start seeing me with it, when they have pretty nasty chronic sinus infections. They've been probably irrigating with their neti pots with nasty water, and then they see ENT, and then we see them. Most patients who have uncomplicated viral sinusitis will have very abnormal signs if you do a CT, and I'll show you some of those. To make the diagnosis of whether it's viral or bacterial, the gold standard is to do a sinus aspiration. Those don't get done, and even if it gets done, they only 60% of the time are they positive, so it's not really worth it to do it. So the problem is, how do you make that decision? And there's no great way to do it, and we'll go into that more here in a second. But people with sinusitis can still have a fever, but usually it lasts for a couple of days, and then it goes. I remember back in med school, I don't know, remember when we used to say, well, if it's colored stuff, that's how you know it's clearly it must be bacterial. That has been totally rebuffed, right? It's rebuffed. You have nasty green stuff associated with virus. Bacterial ones, usually they start right off with a really high fever that doesn't go down, and they have nastiness coming out of their nose that does not go away. Whereas with the viral, it does go back to being clear. Conventional criteria for making that diagnosis, this is really great, except for the fact that I had every single one of these last week. And I am not on antibiotics, and by the way, I'm a lot better. Not 100%, but I'm definitely better. So this doesn't do any stuff at all distinguish between either viral or bacterial etiologies. So the clinical features that you're supposed to be looking at, all of these are exactly the same all the way across. This is maybe getting into things that might help you out. So allergic bilateral, viral bilateral, this is unilateral. So maybe that can help you out. Again, the mucus here, where'd my thing go, is to be purulent the whole time. I guess in more than 10 days. Thank you very much, intermed doctor. And the fever oftentimes will come and will stay. Maxillary toothache, I love that. So sometimes, I remember seeing a patient one time who came in and said, oh my God, I know I have a sinus infection because my teeth hurt. Really? where do your teeth hurt? This one down here is killing me. See your dentist, because I guarantee he'll give you antibiotics. All right, so this is wicked cool. So this is an old study done back in 1994. So they took 31 people and they did CT on everyone. And none of these, this was really relatively early in the course. So here's day 5. Look at these. There's an air fluid level in that maxillary sinus. And ethmoids are a mess. And then on day 18, it's still, I mean, it's clearly better, but there's still that's in there. But now, everything's starting to open up. That was subject 3. Subject 5, the same thing. Total opacification of that left maxillary sinus, a little bit in here. Day 15, it's gone. It's with no treatment. Okay. So of all of the patients that they looked at, 87% of them had significant abnormalities in their maxillary sinus, 65% in the ethmoid, less in the frontal, and obviously less in the sphenoid. So to keep in mind, when you're feeling all full and stuff, you could reason for it. So really great clinical findings that just on exam that are going to help you make that diagnosis. The dental pain, again, they're not all that helpful. Maybe it can do one way or the other, but really it's the time course that you really have to wait for. I think should be up in the exam room. So here's the patient with a fever. There's the purulence, so minimal but probably more watery. Now it gets nasty. Oh, it's coming down by day 10. Now the patients are a little bit thicker. It starts out not too much purulent drainage, but then it picks up and it stays up. And then they have low-grade fevers. Usually start out with the viral stuff, so it goes up pretty high, but then it's kind of more low-grade. These are the, really patients who either are past 10 days or they come in and they're really sick right from the very beginning. And those, again, are pretty uncommon that you're going to see those. So despite the fact that 81% of patients will get antibiotics, 70% of them will actually improve without antibiotics at all. But when you give them a pack and magically improve at day 10, they love that Z-Pack, man, because it worked really well. But if it's really truly bacterial, what you should be using is really amoxicillin or augmentin. This is back to your comment. So what I usually do is ask, do you have rugrats that you're living with? If you got little kids at home, if you are a preschool teacher or something, you are living in a cesspool, right? So the reason to use augmentin as opposed to amoxicillin is that amoxicillin will not get H flu at all, right? So that's the reason to go to augmentin. If it's someone who's older, not around rugrats, like Dr. Bond or something, he could get by with amoxicillin. He's much older. And cycling. I want to spend some time talking about that because there's a really good choice also for sinusitis.
How did the IDSA guidelines come down and say they made a change? So
when you look at the data behind that, there's not good data at all. They do say augmentin, but this is because of the amoxicillin with H flu. So I think you can try to stratify that a little bit. Clearly, if you start out someone on amoxicillin and after day 3 or 4 they're not getting better, I would have made the switch to augmentin at that point. But I search for a reason to get them augmentin. But people have higher risk of side effects. Right? Diarrhea risk is much higher with augmentin than it is with amoxicillin. So again, if symptoms are more than 10 days, if they have a high fever and they're getting worse, and if they have that double sickening, so you're sick, you're starting to get better, things are going great, and you get sick again, usually that's, I envision bacteria that are like just sitting around the top of my head just waiting. Now, nice, warm, moist spot. It's just a great milieu for those bacteria to go in and set up shop. So it's bacterial infection. For the most part, it's going to be strep pneumo, varicella, or H flu. Strep and staph are very uncommon, so you don't have to really worry about covering that at all. You don't need 10 to 14 days. It's 5 to 7 days, and you are done. That's a big change. And then using nasal saline just to be able to loosen up all the stuff that's in there has really been found to be helpful, as well as intranasal steroids to try to shrink down some of the mucosa and be able to get more drainage. That 2% that we've already talked about. So this was a review back in 2012 to look to see, is it really worth it to use antibiotics or not? And as you can know, anything to the right says, yes, we should be using antibiotics. To the left is no, or favors just placebo. Yeah, here's where it sits. So barely over the line. So their benefit, yes, but in very limited situations. So they went and did it again in 2018, and they looked 3,000 patients and found that the number needed to benefit 19, but the number needed to harm with antibiotics was only 8. So there's a lot of downsides to using antibiotics. Antibiotics, 46% were after a week and 64% after 2 weeks. If you use antibiotics against patients that do have bacterial infection, you definitely cure them faster, but only in a small percentage of time. 10% of the time, maybe, the purulent secretions go away faster, but there's a 13-fold increased side effects. So the C. diff that we're seeing, a couple of years ago we had a horrendous outbreak of C. diff at Maine Med, and people were getting colectomies. It's a very frequent occurrence that several times a day people were getting colectomies for C. diff. Luckily, that has lessened some, but recently has started to kind of come back. So we are really worried about C. diff again. So here, the treatment, and this is just referring to Andrea with the with the Augmentin here. Whether or not it's 500 TID or 875 TID, that's, each one is fine. And the second-line drug, or if someone is allergic, doxycycline 100 BID. I've never used 200 once a day. I've only ever used doxy 100 BID. Has a beta-lactam allergy, doxycycline. I'm very about fluoroquinolones. I'm really using them these days, so I would really caution you to not do it. And we'll talk about the new FDA that just came out for that. The other thing I would say about doxycycline is I always caution patients to make sure that you drink a lot of water with those. I have a patient who's a physician who decided to treat herself with doxycycline, and she dry swallowed it, and it got stuck, and she worked for a week and a half because she has such a severe esophagitis. So that's a big problem. She learned a lesson, a tough one. So the antibiotics to avoid, macrolides. If there's greater than 30% strep pneumo resistance, which we clearly are, and I'll show you that map, then you're using macrolides at all. And it's definitely not recommended for H flu because the resistance rates are so high. Bactrim, definitely not recommended, again, because the resistance rates for strep pneumo and H flu are so high. And variable rates of resistance for the cephalosporins. This is scary. So red is, the blue is when they started really pushing azithromycin sales, and the red is the resistance. It is impressive to see how quickly that took off. Those guys did one hell of a job getting out there and getting people to use that drug. It is scary. So, work. Actually, I think I have a picture next that will explain this stuff more. The problem with Zithromax is that the serum levels are really, really low, but tissue levels are high. So you're just giving those bacteria just enough of a nudge for them to become resistant, able to kill the bacteria off, right? So that is really what the major issue is with this. And so we all get our jollies in different ways. So I'm excited about these types of things. So this one of the ways is that the antibiotic, which are these little red ones, goes in, and then the bacteria can have a phosphate group, and it inactivates the antibiotic. So that's great. This is my favorite one right here. This is an efflux pump. So the antibiotics get in, and the bacteria goes, boom, out the door. They kick them right out. And that one works really well with macrolides. sometimes the bacteria will actually modify their target. So now that antibiotic can no longer sit in that. So change the cell wall so they can't get in. And then this is the scariest one. This is a plasmid. So you guys ever seen that? I should have put this in. There's a really cute little cartoon of two bacteria in their plasmids in there having little bacterial sex parties. And that's how you end up getting all this resistance that goes out to all these other different bacteria. So it's not just in one type. It can go between types. So it becomes a real problem. So macrolide resistance to strep pneumo in 2014, 43% of our strep pneumo isolates in New England are resistant, and as a matter of fact, 31% have high-level macrolide resistance. There is really any place in the United States, some states have 31%. That is the lowest amount of strep pneumo resistance. So we have blown it with that drug. We really have. Pretty free. Okay, so this is the other thing that excites me. There's something called UCAST, which is looking up in MICs basically over in Europe, and we use it a lot here to be able to compare. It's a pretty good way for us to look at what our susceptibility should be here. So here's the antibiotics, the MICs to strep pneumo. And so if you look at azithromycin, you can see the MICs to, which again, with lower MICs, the better off you are. It means it's going to work really great. So it works really good here. But geez, what's this? So now starting up above an MIC of 8, not a happy camper, right? Look at any of these isolates have MICs way above 8. It's very, very scary. And then look at amoxicillin, it's around here, 0.004. That is like wicked cool, right? It's amazing. It does not take into account the H flu, though, right? That's where you would come to get nailed with that. So I used cefuroxime as my second-generation cephalosporin to show you guys it goes out here. Clarithromycin, it's not as bad as azithromycin, but it still goes way up here. Doxy, for the most part, 0.5. It does go up, but the vast majority are here. So if someone's on antibiotics, let's say they're on the amoxicillin, again, if they start to get worse, you might want to think about escalating a little bit. If they're continuing to get worse, maybe they're the ones you do send to ENT to figure out, wait a second, are we really breeding a superbug in here? Just sticking a swab in there and getting a culture is not reliable. There's some nastiness that sits in our nose that really does not play a role at all. You've got to get into the sinuses to really know. But again, it's only 60% effective if you get into the sinuses and do those cultures. Since last night, I'd never heard of this before. I don't even know how to say it. So actually, the group did a review on this herbal remedy, which I didn't even realize that they did. And actually, we had these great reviews of course, it was going to like cure cancer and stuff. And what they found was it possibly helps to alleviate some of these symptoms. And it's surprising, you know, you start looking at this stuff, and it's in a lot of these over-the-counter drugs that people are buying that I was a little bit clueless about, to be honest with you. But it shortens duration of sinus and bronchial irritation. And it's a seller in Europe, just to let you know. All right, 2 slides, I think, on bronchitis, because I want to highlight the viral word right there. Cause of viral bronchitis can last for up to 6 weeks. Have antibiotics, again, you don't need them. It's viral. For more than 70% of the time, people who come in with a cough are going to end up with an antibiotic. They don't. Viruses and allergens, and again, much more so than bacteria. Basically, unless you've got pneumonia on exam, you should not be giving out any antibiotics. That contrasted, though, with acute exacerbations of chronic bronchitis, which is usually bacterial. Those people definitely do need to be treated with some antibiotics. All right, things about why you should not use zithromax. Let's talk about pertussis for a little bit. So I always think it's good to remind people about this, that that incubation period can be up to 21 days, right? So you get exposed 3 weeks ago, it's been growing and incubating, having its little way with yourself, and then all of a sudden, here is when you start having symptoms. Your nose starts to run, your eyes start to run, feeling pretty miserable, and during that time is when you are communicable. So once you start coughing, for 3 weeks is when you're communicable. Then go into the whooping stage, but unfortunately adults don't usually whoop, just the kids that do. And then it takes months, right, before you're better. So here's the problem. These patients usually come in, they got a hacking cough, they're not whooping. They're usually misdiagnosed as bronchitis. So maybe put on antibiotics because they just sat here and listened to me yell about why you shouldn't be, which is great. Most of the time they have a dry cough. Luckily, it doesn't happen in adults all that much, but we do have outbreaks, right? That's the problem. The cough can last, again, for a very long time. I just did one of these swabs. I had to do a video how to do the swab at Maine Med, and Zaki was the recipient. It was actually pretty funny because his eyes were watering by the time I was done. But people forget you have to really push those things in. You know, you got to use that foam swab, and you really got to get in there. And patients will not like if you do it right. Patients don't like you. Bottom line. And then you have to set it off for that PCR. And normally you're going to treat, if in fact it's true, you're going to treat them with a Z-Pak or clarithromycin. I don't know how many of you have ever taken clarithromycin. It tastes terrible. It's like you just came from the dentist and had like 19 fillings and a lot of drug intolerance, drug interactions. So I never prescribe clarithromycin. But if you cannot use a Z-Pak, Bactrim is your alternative. So here's the problem. You get antibiotics by year, so while you're still coughing, but you know it's been 2 weeks into the cough. If you get the antibiotics by then, it's not going to shorten the duration of what's going on, but it may decrease the infectious period. So I've just told you why you shouldn't be using azithromycin. Now I'm saying, yeah, but for a community, if there is an outbreak, it is something to think about, right, to try to decrease transmission of the Bordetella. All right, so now this is, you know, when I was growing up, we always had discussions about needs and wants. Funny how we seem to not fall in the same category as needs. This is basically what patients want, right? What they need and what they want are not always the same thing. So getting them to understand that is not always something that's easy to do. So here's your options, right? When you have to decide, does someone have Bordetella pertussis or does someone just have viral bronchitis, and do they just need over-the-counter stuff or need their antibiotics? All right, now we'll talk about the new FDA warning that just came out about fluoroquinolones. I'm hoping that everyone has seen this, but it's pretty scary. Back in June, there was the first warning came out about this, suggesting that there was an increased risk of aortic aneurysms in patients who are on fluoroquinolones. They looked a little into it and they said, yeah, we don't think so. It's a big deal. Don't worry about it. Then another study came out suggesting it again, and then this last study from Sweden came out, and that's what made them say we might have a problem here. So the alerts came out, and they said you got to be really cautious about having these either ruptures or tears in the aorta. So the reason is because fluoroquinolones affect the extracellular matrix, and they actually start to degrade that, which is why patients end up with Achilles tendon ruptures, right? And think about it, a lot of that collagen is still part of the matrix around our aorta, and that's what the thought is here. So this observational study basically showed a 2 times increased risk of aortic aneurysms associated with fluoroquinolones. So it really wasn't as much, they were looking for both rupture and aneurysms, but they found many more aneurysms than ruptures. So basically it was this observational study in a very closely matched cohort, and it was done in Sweden. You had to be 50 years old or older. It was done between 2006 and 2013, and they basically excluded people who'd been on recent antibiotics, who had been in the hospital. You could be on a prescription drug within the previous year. So they were trying to limit the exposure for a lot of different things. And if you had any drug or alcohol problem, you couldn't use it. And clearly, if you had a history of an aneurysm, you couldn't be in the study. So they kept narrowing this down, and finally, they ended up with 360,088 episodes. So one person could be in there more than once with the fluoroquinolones. And then they used amoxicillin because they had no information that suggested there was any problems with the extracellular matrix of tendons and things like that. So that they used amoxicillin. So looking for the first diagnosis of aortic aneurysm or dissection, and the end point was within 60 days from the start of treatment. Found was huge, but it definitely was, 1.2 cases per 1,000 person in the fluoroquinolone group, which actually ended out to 64 cases, whereas 0.7 cases per 1,000 person years, which equated to 40 cases in the amoxicillin group. So there was a 66% increased risk when they did all the risk stratification. Most of that occurred in the first 10 days. Interestingly enough, the Achilles tendon issue is actually further out. It's 15, 30 days. So they're not really sure how to put that together right now. The second part of the study, they actually looked to see where else did you have these in those 10-day increments. And down here, around day, oh, I can't, oops, sorry. How do I go back? So 31 to 40, which is around the time for the Achilles rupture, is when they saw another blip. So again, clearly it was up here the first 10 days where there was a real problem. Pretty stable all the way through for the amoxicillin. That's it in fast form. The feeling was if you can avoid it, you really could. So we at Maine Med, so we do antimicrobial stewardship at Maine Med, and so we are really looking at patients. So if you have, hypertension, any kind of peripheral vascular disease or, arterial disease, we're looking to really try to minimize any fluoroquinolone use because it could be a real problem. We don't know. For them, we know that the first 10 days is where it mostly was seen. So there's going to be a lot of studies that are going to be done starting now, looking at coming forward. And I'm sure that the fluoroquinolone manufacturers are going to be very interested in seeing where this stuff goes. Last few minutes, I have a couple things I want to talk about. This is my pet peeve, is penicillin allergies. So I will say that I've been trying to look at the number of patients at Intermed who have penicillin allergies, and they sent me a list which ended up being in the thousands, which was a little overwhelming for me to sit down and go through every chart. It drives me nuts when a penicillin allergy is I puked once, right? That is not an allergy, and I would really ask you guys to try to push patients to figure out what the allergy is. Really, there's a new study that just came out, and actually less than 5% of patients are truly allergic. And in fact, if you actually had anaphylaxis years ago, there's an 80% chance that you have outgrown that, and you are no longer allergic at all. But, 80% after 10 years. And remember that there's a less than 2% cross-reactivity between penicillin and cephalosporins.
I think this is the most common thing I get from patients that I know it happens when I was a baby, and I told them I should never do it. I guess I generally avoid because I don't really know, but in cases I'm laboring and delivering when I'm deciding between, cephalosporin and
right.
But how can you figure it out if you really need to know?
Thank you for bringing that up. So basically, if someone has GI stuff or headache, you can give penicillin. Right? I don't really care. If they have hot or they get, that did not sound good. You know what I mean, okay? If they have shortness of breath, you can do a penicillin skin test. That's what I've been trying to look at. We're trying to work with the allergists to try to see which patients at Intermed are getting ready to have surgery, the penicillin allergy. Let's jump in and do a penicillin skin test on them so we can wipe it off their chart. So if they need antibiotics down the road, I don't have to worry about stuff, right? Because being penicillin allergic, there's been good studies that show that you do worse if you get an infection because the drugs that are used are not as effective. Okay, the penicillin skin test is pretty good, man. 95% negative predictive value. So it's really very helpful. We're still working on that. Stay tuned. If someone says, well, yeah, I stopped breathing, I'm like, I'm done. Okay, I'm not going to be able to do that. But I will send them off to an allergist, because if it was 20 years ago, I let them do that test in their office. See, I just don't want to do it here. So here is just one quick study that looked at the difference between Vanco and beta-lactams for methicillin-sensitive Staph aureus. Patients come in and go, oh, yeah, I'm on that Vanco. It's that big gun. It's the best one that's out there. Vanco stinks for MSSA, right? You need to have a beta-lactam in there. And this shows it, right? So here's patients that are nafcillin, boom, their colony-forming units drop right down. From Vanco, and this is, you remember the tortoise in the hair? This is the hair. Here's the tortoise. It's taken its sweet little time to take care of that infection. I'm going to say, new drug coming in the road called amitriptyline. I hope you guys don't really see it, but you're going to hear about it. And basically, it's a new and improved tetracycline, and it's got a much broader range of activity than what clearly better than tetracycline, but also better than doxy and minocycline. It's going to be used for a lot of immune-acquired pneumonia and the soft tissue stuff. The good news for me is that the first couple doses have to be IV, and then you can switch to PO. So I'm not worried about this being used in the outpatient setting right now. People are going to be coming back at some point on the oral form because it is available now. But if you start using this, it covers a lot of different drugs. We're using this a lot, and we're going to run into trouble, just like we did with put this in here. Many of you sitting in here don't know Carl Hackmiller. However, he was my senior for I don't know how many years, like throughout all medical school and residency. And he used to say, there are assassins everywhere. And it really is true. The antibiotics that we use, although good, can come back and hurt people in the long run. That's it. Any questions from anybody? Good. Thank you.
Thanks, Sam.
Awesome.
Thank you.